Okay, we are going to get started with our next session. So if you are in the other room, grabbing your snack, take your time. No worries at all. We are really delighted to have Dr. Julia Valliant join us virtually today. As I said, she was going to be here in person, but 'tis the time of year for illnesses and viruses, and thank goodness we do have the ability to connect virtually now, right? Whereas before you had to make that difficult decision. Do I just, go and hope no one notices I'm coughing and sneezing in the corner? So if we will pull up our next speaker, I think you'll like those of you that love data and research and also love the idea of using local food as part of the food as medicine movement. She brings all of this to the table. So I'm going to let her introduce herself and take it away. Thank you again for joining us.
Absolutely. You're welcome, and thank you, Elizabeth, for inviting me to be with you. Hi, everybody. I am calling in from Indiana, where I am at our flagship university, Indiana University, where I'm on the faculty. I'm a scientist with our group that's called Food and Agrarian Systems, and my background training is in public health. I'm sure you're having a lovely day together. I wish I were with you. Let's see. I have a big old soft spot for Kansas ever since getting to work really regularly with your Kansas Rural Center a few years ago for one of our studies. And then recently, the television show Somebody Somewhere became my new favorite. It's set in Manhattan. Maybe there's some fans in the room, and you can let me know if you are. Anyway, so I wish I could be with you today, but here's what we're going to do for this session. Okay, I'm going to briefly overview the 4 years of work that our university group has been doing to plan and deliver and evaluate FIM programs in Indiana with our local partners, and to fund and facilitate our partners throughout our rural region to create and run their own FIM innovations. So first, we'll look at our original pilot program, which took place 4 years ago, and what the outcomes of that were. Then we will turn to looking at how that work expanded over the next 3 years to serve people in 7 counties through a bunch of different approaches, all united by one model of FIM. And then I'll wrap it up by finishing on reflecting on some takeaways from our work and where we would like to take it next. Anyway, so I guess just raise your hand or chat me or pipe up if anybody needs to let me know anything, but I'll just keep rolling.
We can hear you, and you sound great, and there were many murmurs of appreciation when you mentioned the show based in Manhattan. So you've Kansas fans in the room as well.
Thanks for feeding back. Okay. So phase 1, our very first FIM pilot. So travel back in time to 2019, 2020, and you will find a rural brick and mortar grocery in southern Indiana near Kentucky that was working really hard to stay in business. The leaders of the store were in regular conversation with the leaders of the local clinic, the local powerhouse clinic, I should say, which is an FQHC. The concerns of the store and the clinic related to one another. A strong suit of the grocery was its sales in locally grown food, and they wanted to nurture this market sector by teaching more of their customers and more people in their community how to cook from whole foods. Whereas the clinic ranked 9th in the state of Indiana for diabetes prevalence and the burden of patients having multiple expensive chronic diseases. So the clinic and the store decided to work together, and they came up with and ran a food as medicine program. Incidentally, this cross-pollination of rural leadership across sectors, food and medicine, was another major asset that this community possessed. And so The program rolled out of the station when the store began to convene winter meetings with 30 local farmers who raise food so that they could plan out what the store would purchase from those farmers throughout the growing season. Then, when spring came, the store began a routine of weekly pickups from farms. Okay, to situate us on the map, here's how you get to where we are from where you are. First, you drive to St. Louis, and then you hop on I-64 and drive east for 4 more hours, and you're nearly there. It's very near Louisville, Kentucky. And it's a distinctive region for the Midwest because the land is really hilly and really rocky. And so it's not much used for row crop agriculture. Instead, there is a lot of public forest land and a lot of space for people to create small food farms, which they have been doing. The history of the area features a lot of Quaker settlement, some racial diversity, mainly in the past. And recently, it's become a center for Plain community or Amish and Mennonite settlement. So, a real asset of this region is production of local food, self sufficiency in food production, and direct sales. The region is rural. You can see on the slide that it has 45 people per square mile versus higher than that for our state as a whole and the country as a whole. And it's lower income. The median income is about 65% of the US national median income. Okay, so the first funders of our work in FIM were our own university's Center for Rural Engagement that funds efforts to research, run programs, and teach in rural parts of our state. In turn, the Center for Rural Engagement is funded by our statewide Lilly Endowment, which is funded by Eli Lilly's pharmaceutical company. Okay, so phase one, our first food as medicine program, was called the Farm to Health Nutrition Box. And here's some features. It was a super low dose program. All it did for 3 months was provide participants with 1 meal kit per week. That's it, just 1 meal. There are programs around the country that are a lot higher dose and more ambitious, and these are exciting. Some programs that provide families with 10 meals a week or all the meals of the week. This is just 1 meal. There was also weekly education by a local dietitian, and she more or less followed the Cooking Matters curriculum. All the recruitment of the participants was done by the local FQHC. And seeing as how this is all getting going in 2020, there were beautiful plans for lots of in-person events that needed to pivot to virtual. Here is a calendar of the seasonal meal kits that the store designed and provided to people in the meal kits. So I don't know how well you can see the slide, but it carries us from June in the upper left, going down through July, August, and then the right-hand column shows us September, October, and November. Because there were different waves of groups of people who went through the program. And so the recipes were tailored to reflect local food when it's abundant and low cost, basically. There are some amusing things on this calendar which show you how it's a community designed program rather than a nutritionist designed program. Because on a couple of those weeks, the main dish that was provided was salsa, first melon salsa and later tomato salsa. And there was 1 week when they just threw in the towel and provided people basically with pigs in a blanket called crescent mummy rolls. Anyway, so the food lineup is amusing if you're trying to change people's nutrition and their clinical outcomes, but we were able, as the university research partners, to just throw in behind what the community was developing and rolling out and add an evaluation piece onto what they were doing. So we were able to actually do a randomized controlled trial of the Farm to Health program. All the participants who were recruited by the clinic had diabetes. 60 people were recruited and provided consent. And then half of these people were randomized to the intervention group that did the full program, and half were randomized to the control group that earned incentives and participated in the data collection events and the interactions, but did not receive the food or the education. Then we followed up with everybody at 3 points in time, first at baseline, then when the program ended after 3 months, and then a half a year later to get long-term measurements. Here's who signed up for the program. This table compares the people who enrolled in the study with the general characteristics of the 2 counties where they live, with the country as a whole. And you can see in the first row that food insecurity was much more prevalent among the people who chose to sign up for the study than in the place in general and the country in general. Their education levels differed a bit too. We had more people compared to the country as a whole who had not completed high school, more people who stopped at high school diploma or a GED, and fewer people who had been to any college at all. Their racial makeup reflected that of the counties where they live. Everybody said they were white, and 3% of the people said they were also Native American, which is substantially less diverse than the country as a whole. And disability was also much more prevalent. Disability of one form or another was much more prevalent than in the country and the counties as a whole. So here's who worked with us in the Farm to Health program. Some other characteristics that they shared was that it was pretty common for their income to be interrupted at some point in 2020 or 2021 by the pandemic. Their internet access was pretty good. About 3/4 of them said that they have good internet at home. Their average BMI or measure of obesity was 38, which is solidly obesity range. And their average hemoglobin A1C, which is a marker of diabetes, was 9.3, which is solidly diabetes range. And this kid is holding a food box filled with their family's meal kit for the week. Okay, so here are the differences that we saw between the people who did the program and the people who were in the control group at the end of the program and then later during long-term follow-up. What we saw was that people tracked together pretty well during the 3-month program, but then differences emerged between the 2 groups during the longer-term follow-up. As a rule, we were surprised to see that the people who had done the intervention program kind of stabilized, like some of their outcomes improved or stopped getting worse. Whereas the people who had been in the control group, some of their markers continued to get worse. So we did observe that the intervention had a protective effect on people's health. The clinical markers that saw statistically significant changes were obesity and diabetes. The people who did the program, their BMIs improved. The people who were in the control group, they worsened. And their diabetes markers stabilized among the intervention group while they continued to worsen among the control group. So these are very wonky, scientific results that we are finishing writing the paper up about now, and we'll ship it in soon to a journal. So if this kind of thing happens to interest you, please contact me because we're looking for ideas for journals for where to send it and anonymous reviewers to suggest to editors. A couple other differences we saw is that people who had done the program were more likely than people in the control group to start choosing low sodium foods and to start eating more salad. So those are our quantitative results. We also sat down and spent a lot of time doing interviews with people in the program. A methodology that we followed is called the most significant change, where you ask people So, what was the most significant change that came out of the Farm to Health program for you? And then you ask them a couple follow up questions about it. And some people had fabulous things to say. Like, I just remember one person saying, "Well, look at the difference in us in 3 months' time." And then she went on to recount the ways in which they were eating in ways that were more satisfying to them and taking good care of their health and seeing effects on their health. I brought you today, sorry. Okay. I brought you today an audio clip from one of the participants talking about some of the food changes that the program inspired him to make. So, what we just heard him say was driving a truck, I don't have a lot of time.
Julia, we can't hear it on this end. Are you able to hear it on your end?
Yeah, I'm hearing it. Okay, so I'll just give you some highlights. So basically, he has a cool story because he's a long distance trucker. He's watched his health deteriorate over recent years and he's determined to improve his health. Some of his numbers are scaring him. So, what he does is he has this whole regimen of chopping vegetables before he goes, bringing his crock pot with him in his truck, bringing cut up veg with him in his truck, and he's just rearranging how he uses food when he's on the road. And he's seeing effects on his health. Okay, thanks for letting me know, Elizabeth. Um, okay, so that's the overview of our first phase. Then, as we were gathering and beginning to analyze those data, we moved on to our second phase, which expanded our delivery of FAM programs and experimentation with them from the 2 original counties, which are in dark orange, to a 7-county area. And we called this Southern Indiana Food as Medicine. So, in our second phase, what we wanted to focus on was partnership building between rural leaders who work in different sectors, like the leaders I mentioned earlier who worked in food and who worked in medicine and who came together to build a food as medicine program of their own design. We wanted to focus more on these partnerships. And one reason for that was because we had been through the pandemic. And the quotation on the right is from Brandon, who ran the Food as Medicine program for the rural grocery store. And Brandon said, "We saw the fragility of the global food system firsthand, not being able to get orders. So we are creating a safety net on the chance that something like that would happen again." What he means is that they're continuing to focus on building their sourcing from local growers who are really nimble and able to pivot and serve grocery stores when the global food supply chains got interrupted for a while. Another thing we are doing in the phase 2 is expanding the coverage of that rural grocery from 2 counties to 4. And the funders for phase 2 were the Center for Disease Control and the Indiana Department of Health. Okay, so here's our model of food as medicine. Um, in all of the places where we have been working, we have these 3 types of partners. One on the bottom right are the growers or the aggregators or the suppliers of food and especially local food. We've been trying to focus on sourcing local food. We have the nutrition educators and we have the health providers. And the picture in the background shows you the ingredients for one of the recipes that people learned to make. It was like asparagus, chicken, something, I forget what. So basically, this is how all the programs in all the 7 counties have been working. Step 1 is to plan a seasonal recipe calendar featuring local produce when it's really abundant and doesn't cost much. like that time of year when everybody has zucchinis coming out their ears. 2, recruit and enroll participants through public health or medical partners. 3, buy the food, build them into meal kits, give them out, and provide people with any of the kitchen tools that they're going to need in order to cook that recipe. So that's part of our program too, is giving people knives, cutting boards, pots, all the stuff that you need in order to actually be able to cook from scratch at home. 4, teach participants how to cook the recipes and about nutrition. And then 5, assess how it all went for partners and participants. So, seeing as how the partners in each of the 7 counties were designing and coming up with their own FEM interventions, there was a really wide variety in what those have been looking like. So, just to provide you with some examples of a few of the partners, some of the food partners have included farmers markets, farm stands, farm markets, one mobile farm stand, and local grocery stores. The nutrition educators are typically from our land grant university extension service educators. They're great partners. And then the health providers have really run the gamut from perinatal navigation services, a food pantry, a homeless shelter, senior housing communities, a senior center, and 4-H. Okay. And here's an example of one community that sources food from the farmers market and takes it once a week to the senior center where the people who work there and who have still a kitchen where you can cook prepare it for the seniors who come there for lunch. This online referral tool called HoosierHelp.org is has been a central part of our work. People who live in Indiana, our nickname is Hoosiers. No one really knows why. So we have Hoosier Help. This has been one puzzle that emerged was around data sharing and MOUs with our recruitment partners, and a tool that simplified the recruitment and referral process for everybody was HoosierHelp.org. This tool allowed the community health worker or the perinatal navigator who was asking her clients if they wanted to sign up for food as medicine, allowed her to directly and easily refer a participant into the program when the participant was interested. So, Hoosier Help refers to lots of types of public health services. The most hits they receive, the most searches are people looking for food and looking for housing. And one of the leaders of HoosierHelp.org is there in Topeka with you from Indiana. Her name is Chelsea Simpkins. She was with you today. You'll see her again tomorrow. She had to go finish an assignment because she's in grad school. And another thing to know about Chelsea is that she's also on staff with our university's brand new Center for Community Engaged Dissemination and Implementation Research. So if you want to get wonky with Chelsea and talk about online referral tools, she is your person. We were excited that the costs to deliver our food as medicine programs stayed pretty low, even though we were sourcing local food. We did a comparison here to what our program cost relative to a couple of other common, like receive your meal kit at home and slice and dice and cook it yourself. Our program, the food alone in one of the counties just cost $4 per kit. When we factored in the cost of labor, that brought it up to about $7, which was less than the 2 national models. This slide lists other costs that we ran into in some cases with some counties' programs. And then here you see 3 more of the recipes that people learn to make on the bottom, using local produce and other foods as well to round out the meal kit. Okay, now to wrap up today, I just want to provide you with a few reflections on the work we've been doing in FIM. Okay, so pros and cons of our model. Something we've been really liking doing is this meal kit approach. But then there's some funders who only fund purchases of produce. So for us, that's a little bit of a puzzle of how to move from where we've been to what they're funding. So there's a tension there around meal kits and funds that people who are doing FIM can access. We've been keeping our costs low, but our programs have been grant funded. We need a sustaining investment source. And since our costs are low, a $4,000 donation from a company can launch a food as medicine program to run for a couple of months to affect a lot of people. But at the same time, it would be great to have a real long-term solid source of investment in food as medicine models. For example, from insurers or employers in their benefit packages or from policy. And nationally, a really good case for that is being made in terms of the evidence of the effectiveness of FIM and its cost effectiveness and how competitive the effectiveness and the costs are with standard pharmaceuticals that are always covered by insurance. So that's exciting. Another thing that's really nice about our model is that it reaches whole networks of people. An individual person enrolls and then they go carry everything they're learning to everybody in their household, their extended kin network, their workmates, their neighbors. So, a couple of final summary thoughts. We've been excited that even our very low dose program that's just been providing people with 1 and later 2 meals per week has led to changes that are clinically relevant. I think that's saying a lot because what we've been doing hasn't cost all that much and it hasn't been that much, but it's inspiring people and helping guide them as they turn towards caring for their health more with food. We really want to continue building partnerships between the research sector at the university and program delivery. And we also want to continue cultivating local rural leadership across sectors. We've been finding in our work that rural farmers markets and rural groceries are a huge asset in terms of partnership because they're places where people who are raising food locally are already coming together and vending and aggregating the food that they raise. Our community partners who don't have a farmer's market or a local grocery have been a lot more challenging to work with. And so it just helps me see the value of a rural farmer's market in a new light. And then like I said, it's really thought-provoking how the programs are reaching whole networks of people. You enroll one person and they carry it to everybody who they know. And I think there's something there in terms of experimenting with future delivery models. So that's what I brought you today from our work in Indiana. Here's just a thank you slide to our many partners across our 7 counties and lots of people here at IU who have been central to the work. And here's my email address at the bottom. If anybody wants to write to me, it's real simple. It's just my initials, jdv@iu.edu. And if there's any questions in the room, I'm happy to take them. But if folks want to keep moving towards your next cup of coffee or your next speaker, I understand that.
Can you hear me now, Julia?
Yeah.
Okay, I'm sorry about that. I don't think It's been a day. We'll leave it at that. Those were beautiful slides. Are you all right with us sharing those with participants in the PDF format after this conference so that they can follow up with them? Excellent.
Yes.
Okay, thank you so
Definitely.
much. Does anyone have a question before I launch into mine? Okay, let's. Dr. Alice Ammerman from University of North Carolina, Chapel Hill has a question. There, I just introduced you for you.
Thank you. Wonderful presentation, very inspiring. Kind of a nerdy research question. How were you able to snag people to get the measures, given it was a community-based study, like to get the more clinical measures?
Oh my gosh, we did so much work. We convened a series of data collection events at the grocery. So people could go to the grocery, and we had nurses stationed there to take their vitals, including blood draws or finger pricks for the hemoglobin A1C. And also, when people came there, they also filled out questionnaires and did an interview and picked up an incentive gift. And then anyone who missed the data collection dates, we followed up with them separately. And they could go into the clinic and provide their measurements and do the questionnaire with us over the phone. And that worked out well. It was a lot of work. People came, it was festive, and then we did a ton of follow-up people by phone and text until we really heard from people, and people stuck with it because almost 80% of people went all the way through and did all the steps.
That's great. Very impressive. Thank you.
You're welcome.
Other question?
Thank you, Julia. Jennifer Garner here. I'm at University of Michigan School of Public Health, and a lot of intersection with our work. One of my key partnerships is in southeastern Ohio, Appalachian Ohio, and one of the key assets of that region is the Amish farmers. So it was really great to hear you mention that because of how they contribute to the local food system. Related to that, some of our nonprofit partners really want to see kind of like your work really helping to enhance local demand for local fruits and vegetables, but also acknowledging what do we do in the off season to create continuity for the participants. So I was curious how you guys tackled that, because I heard you kind of nod to that, like when produce is available, we're encouraging it, but that kind of implies that you are also sourcing in other ways. So I would love to hear how you approach that.
Yeah, that's a really insightful question, and it's something I would love for us to be able to develop more in our work. So far, our work has been taking place during the growing seasons. One year it did continue into like November with some frozen things that farmers had frozen, such as squash. But this is really an area we can strengthen, and there are lots of initiatives to help farmers who want to continue to grow through the winter season in high tunnels. Often people want to take a break in winter and pause on growing food. This is also a place where we see a lot of potential for more winter farmers markets in rural spaces. We do have those here, but they tend to take place in the population centers. So just like farmers markets during the growing season are a huge asset for rural communities, a winter farmers market could be too. So yeah, Jennifer, it would be neat to talk more and kind of brainstorm and strategize around how we could develop it. Because you're right, the participants want everything to keep going because they love it. Yeah, so thanks for your question. It would be fun to talk more somehow.
I'm just curious. We've noticed across the two states of Kansas and Missouri a really huge difference in terms of consumers recognizing what local food means, what local produce means. And so where there are retailers that make a note of like labeling things that are locally grown, people are much more in tune with that. But if that's not happening, then like I've had people call me for the Double Up Food Bucks program and said, "Hey, well I I bought these strawberries. They're Driscoll strawberries. Why didn't I, this was back in the day when we tried to make locally grown a component of being able to earn double up food bucks, which we gave up because in many areas we realized consumers have no idea, absolutely no idea that kiwi is not grown in Kansas. It's just, they think it's local. So if they're buying it at their local store, they think it's local. So how are you, I guess, raising up local so that the consumer is really very much aware that that what they're doing, what they're eating, what they're purchasing, how they're getting food is local?
Yeah, those are smart observations, and it sounds like you all have been doing a lot with experimenting with incorporating local and letting people know about it. Your story about kiwi is funny, and the Driscoll strawberries. And it's such a good question, and I don't know is the answer. Like, I don't know how exactly the materials are interpreting where the food's coming from for the participants. I know that they receive a paper recipe with the food in case they're not able to go online and get the recipe. And I don't remember if that paper recipe tells people, like, okay, the chives and the asparagus and the chicken are all local, and this other stuff is not local. Or if somehow the farmers market partners are letting people know that. I forget. It's been a while since I've actually like looked in the box and looked at the paper material to see how they're interpreting it. But I think it's just taking place like that, like at pickup. And maybe also during the education, because there are live or recorded education sessions like cooking shows that show you how to cook the recipe you've received. And it may be that during those interactions too, that the educators are telling the people, hey, this week we have beets from these farmers and beef from these farmers and onions and garlic and greens from these farmers. And next week we're going to have apple and squash from these farmers. I would think it's through those ways.
Fascinating. Thank you.
Mm-hmm.
Hi, Julia. My name is Trina Reagan, and I've run a food as medicine program using meal kits in St. Louis. And I was curious when you talked about meeting with the farmers to kind of plan out what they were going to be growing. We thought that would be a great idea when we started our meal kits, and the farmers were super hesitant to commit to anything. There was a lot of worry about whether those crops would come to fruition, and so what we thought would be a win-win for our program and them kind of having committed funding and revenue coming in. We ended up kind of having to pinch hit with what they grew every week. So I was just wondering, how did that relationship go? How did you get them on board with doing some winter projections?
Ooh, that's really interesting. And I feel like we should talk more. I should introduce you to a couple of my workmates here because we're so close by regionally. Um, I haven't heard any stories of resistance. I've heard farmers asking for it. I've heard farmers saying, can you let me know what the recipe calendar is going to be? Because I got to figure out how many carrots I'm going to buy and put in the ground. And so actually, the farmers are kind of driving the timeline in many instances. Your question also makes me think about farmers talking about how the regular business that they can anticipate, that they'll know they'll be having coming in from the food as medicine purchasing, has been very stabilizing for their businesses. And they know they're going to have this much revenue from food as medicine. And so some of them even talk about how that's freed them to diversify into new enterprises. Like we have one farmer who talks about Oh, they had always wanted to add eggs to their farm, and it was the regular business from Food as Medicine that let them make that leap and take that step and do that. So I can't think of having heard about any like farmer skepticism or resistance or hesitation around planning. And I wonder if that's because of the region, because they know, like, well, if something falls through with Food as Medicine, we have these other venues where we can vend it. Um, I don't know. That's a really interesting puzzle to think about, and it would be cool to talk more, Trina.
All right. I think we have, you have many more research questions to answer after this. You came to us with wonderful information, and hopefully we gave you some even more avenues of exploration. Please join me again in thanking our speaker, Dr. Valliant.
Thank you all
Thank
so
you
much.
so much. And we will touch base with you again tomorrow. So thank you again.